Hi, very good morning and Assalamualaikum to everyone. Today I'm going to cover upper limb block, vascular access, and also, if we got extra time, I'm going to talk a bit about the scalp block. So, upper limb block is actually the amount of block that we need to talk about is quite a huge number. If we want to include everything, I won't be able to finish up everything. So the only blocks that I'm going to cover is these few blocks, which is interscalene, supraclavicular, and intercostobrachial. Okay, why I choose all these three blocks? Because basically with these three blocks, you should be able to cover all the upper limb, from the shoulder up until the fingertips. So before we go into any further, let us do a bit of revision on the brachial plexus, which is the favorite diagram of any of the upper limb block. So everything starts from the roots, C5 until T1, and then from the roots down to trunks, division, cords, and terminal nerves. For the interscalene and supraclavicular, we can see that for interscalene, we basically are blocking the roots. And for the supraclavicular, it's a bit difficult for us to distinguish between the trunks or division. But basically, if we put our probe at the supraclavicular groove, then we are aiming for the trunks and division. And then if we put our probes infraclavically, we are aiming for the cord, meaning that we are looking at the lateral cord, posterior cord, and also the medial cord. Okay. Going more peripherally, then we are aiming for the terminal nerve, which is at the axillary region. For axillary region, meaning that it's a bit more difficult for us to get a full block of the upper limb because we need to block these 6 separate nerves. And the mnemonic for this one that I always use is MARMU. Musculocutaneous M, median nerve, another M, axillary is the A, R is the radial, another M for the lateral head of the median nerve, and also the ulna. So MARMU, M-A-R-M-U. Okay. So there's 2 important nerves coming out from the roots, which is the dorsal scapular nerve and long thoracic nerve, which are the nerves that we have to watch out during the interscalene block. Okay. And then for supraclavicular, there's a bit of small nerve, but basically if we block properly the trunk and the divisions part, we have managed to block all those small nerves as well. Okay. Now we are going into the more specific nerve. So my lecture for the 3 blocks will concentrate on why we are doing those blocks, where we are going to do it, and how we are going to do it. So interscalene block is basically for any operation that concentrate on the shoulder and also the proximal part of the upper limb. Proximal part, meaning that if you are doing an incision extending from the upper until the elbow, it's not a good choice to choose the interscalene. Better to choose the supraclavicular. But if let's say we are doing some sort of laceration wound, we want to top up with anesthesia just over the shoulder, then the interscalene block will suffice. Okay, and then I didn't write the general contraindication for the block. Basically, if you got the allergy to the LA or patient refusal, then it's considered as the contraindication for the block. But those are the specific contraindications which, if patient got a known case of phrenic nerve palsy or is in respiratory distress, then it's wise not to choose to do the interscalene block because of the complications that might happen, which I'm going to discuss more later. And what are the concentration? We can choose. We can actually choose 0.25 or 0.5. It's really depends. Okay, if we choose 0.5, then the anesthesia is going to be longer duration. But the volume, preferably we limit until 10 mils, because we are afraid that if the volume is too huge, it might cause other paralysis of other nerve as well. Okay, and then the needle used is the shortest needle for the block needle, which is 50 millimeter, 5 centimeter. Okay. Most of the time, if patient is big size as well, 5 centimeters is enough to do the interscalene block. And I'm going to explain why, the reason later. And then it's in the in-plane technique, and as Dr. Nabilah mentioned earlier, our linear probe is sufficient to do this block. Okay? Okay. So first of all, we have to make sure that we are in a ergonometric position. Okay, as we can see, this is both our model here. So it's a straight line between the model, the patient, and the machine. Okay. And then even the injection site also is in a parallel, is in a straight line. Okay. If you can see that the table height also is at patient's waist. Okay. If let's say we choose, if the table can't be level up or level down, you can choose to sit down. Okay, just grab a chair and sit. Okay. So where should we position the needle? And the probe is, okay, as we can see here, this is the clavicle, and this is the sternocleidomastoid muscle. Okay. There's 2 ways of scanning this image to get this image, but most likely the end result of the probe position would be here, roughly above the clavicle in a 45-degree angle and below the sternocleidomastoid. And this is the image that we are looking for. Okay, so here is the medial part, and here is the lateral part, and the yellow arrow indicate the needle pathway. Okay. Most of the time for the interscalene block, we only manage to visualize the C5 and C6 root. Some people might mistake the third hypoechoic structure is C7, but it can be C6, which branch into 2 roots. Okay. And then this structure, it can be C7 or it can be actually an artery. Okay. So it's quite important to do some Doppler or color before we are poking anything. And then this is the anterior scalene muscle, this is the medial scalene muscle, and on top of this is actually the sternocleidomastoid. Okay. So how we are going to do it, there's 2 ways of scanning. One is from the supraclavicular fossa, and another one is from medial to lateral. From supraclavicular fossa is basically you put your probe parallel to your clavicle, and then you scan from the groove upward. But remember, if your patient is a bit on the big size or obese size or short neck, you don't actually have to literally move the probe upward. You just might need to slide, just tilt your probe upward to get the picture that I've shown earlier. Okay. Now just let's watch the video. Okay, this is, as you can see, this is the this is the brachial plexus, and then as I slide above, this is the butterfly that we are looking at. And then this is the sternocleidomastoid, this is the IJV, and this is the carotid artery. Okay, and then most of the time, if I'm the one who's doing the scanning, I would always choose this supraclavicular fossa, because we know where to start off with. We know what to look for first, meaning that we look for the brachial plexus at the supraclavicular groove, and then we go upward. Okay, it's easier to do it that way, but some people might prefer to do it another way, which is from medial to lateral. Medial meaning that we start off from the trachea, and then we just slide off our probe laterally. And then this is the pictures, this is the video pictures that how we are going to get it. Okay, this is a trachea, and then you can see this is the sternocleidomastoid, this is our carotid artery, this is the IJV, this is our anterior scalene muscle, this is the roots, and this is the middle. Okay. If you're lucky, you can get it straight away by just sliding off. This technique is if we got a lean patient and not so short neck, then it's easy to go from medial to lateral. If not, we might have difficulty in locating the roots. And this is just me confirming that this is actually the roots by going up and down to see that it's forming the brachial plexus. These are the two ways. And then your needle will be coming from the lateral side, which is from here. And then for this picture, the lateral side from here. Okay. And then what are the complications? Okay. So this is basically the cross section of the neck at C6 level. Okay. These are all the important structures surrounding it. And if we can see, if we choose a longer needle, if we are poking from the lateral, which is here, lateral is here, if you're poking from here, if you choose a longer needle, you can easily puncture the sympathetic nerve change, which can cause Horner syndrome. And then if you go a bit further, you're going to puncture the recurrent laryngeal nerve, which can cause hoarseness. So that's why it's quite important for us to choose the shortest needle ever, because we don't have any bony structure to actually limit our needle advancement. We only have the muscle there. And it's easy to pass through it, especially those who are not really visualize the needle tip all the way. So for this block, we have to actually visualize the needle tip so that we go over. Pardon? C6 level. So, and then if, let's say, if we come from the medial approach, we don't normally do interscalene brachial plexus block from the medial approach because of this reason. There's a phrenic nerve here. Okay. So if we come from the medial approach, other than poking all the vessels, big vessels here, we can poke the phrenic nerve here. Okay. But why, even though we choose the lateral approach, there's a possibility of causing a phrenic nerve palsy is that sometimes if you poke too high up and then the volume actually spill over there, it can cause the phrenic nerve palsy as well. So interscalene block, one of the things that we have to watch out is the phrenic nerve palsy. Okay, and then let's say if we advance our needle a bit, not towards this part of roots, we advance over here, we might end up in the epidural and intrathecal space. Okay. So that because of all these complications, it's not that we cannot do, we can do. It is advisable to do in order to reduce the opioid consumption intraoperatively, but we need to do when patient is awake. Pre-op or post-op after extubation. Okay. Interscalene block, normally we don't do it alone, meaning that not for pure anesthesia. Most of the time, interscalene is analgesia, meaning that we combine with GA. And then if, let's say, we combine with GA, we do it during patient's awake because of all these multiple complications. Okay. And then for interscalene block as well, we can put a catheter inside for a continuous infusion. Okay. So, any question for the interscalene block first? Around 2 to 3 mils per hour. Concentration is 0.2. Most of the time, the continuous infusion, we use 0.1 or 0.2. But the volume, maximum is only 3 mils per hour. Okay, so we are going, so this is basically just a nutshell about the interscalene block. We are going to the supraclavicular. Okay. Supraclavicular is known as the spinal of the upper limb, meaning that with just one block, we settle everything. So, for any kind of surgery of the upper limb, including our, maybe not until the digits, but including the hand, we can use the supraclavicular block. And specific contraindication, there's no specific contraindication. In other words, let's say if patient has neurological deficits preoperatively, it's not a contraindication for us to do the block. The most important thing is that we have to document the specific neurological deficit, and then explain to patient what's going to happen, and then we have to let the surgeon know as well. Okay. If let's say patients refuse, doesn't want to do the op, doesn't want to do the block, and then the surgeon say it's better not to do, then we don't do. But otherwise, there's no specific contraindication for the supraclavicular. And then the LA consideration also depends on what kind of aim that we want, whether it's the anesthesia or analgesia. So it's 0.5 or 0.2 or 0.375. Volume can up until 30 mils, and it's the in-plane technique, and the needle can be up until 80 millimeter. Some people, if those who are not used to do blocks yet, maybe they want to choose a longer needle. But then the problem with longer needle is that if we tend to overshoot it, hitting the lungs. So before we choose our needle, we just do a pre-block scan and we see how far is the structure from the skin.
How long will the effect last? If I think about it?
0.5.
How long will the effect last?
The anesthesia part, the numbness, up until 24 hours actually. The numbness, the dense numbness would be the first 12 hours, but the numbness will persist there up until 24 hours.
So it causes numbness or it takes away the pain?
Pardon?
Causes the numbness or does it take away the pain?
It takes away the pain, meaning that patient will be pain-free. So when we explain to the patient during the consent taking time, we have to explain to the patient that they might feel the numb up until 24 hours. But don't worry, we don't come and have a review, everything. So sometimes because they don't feel the pain, they feel the numb. They will be more worried about the numbness because they don't feel the pain anymore. No, the pain will be there if the numbness is there. What worries us if the pain is there and the numbness is there. That means that the block might not working or there's something wrong. You might be hitting the nerve or something like that.
So elbow dislocation, elbow dislocation, not then.
Okay.
But then you have to use probably lesser volume.
The volume, I would suggest up until 30 minutes. You can adjust the concentration, meaning that if you want to put 0.375. But if you want a longer duration, meaning that if you 0.375, it might last until 12 hours or 6 hours. But if you want to last until 1 hour, 1 day, might just use a 0.5%, the concentration.
So you're using the 0.5 concentration for aiming for a longer duration because you're aiming for higher volumes.
Yeah.
So the volumes will have an effect on your anesthesia rather than the dosing.
No, the volume.
Which one is the most
The most important one. Okay.
You want the volume or you want the concentration?
Actually, for the longer duration, I would want both.
That's why you
For the dense part during the operation time, okay, we would choose the 0.5 because 0.75 will be too long.
If I don't reduce the volume.
Reduce the volume, then later on the distribution, the spread.
So aiming for the spread is why you're aiming for the volume.
So sometimes if the spread is good with 20 mils, then we can just give 20 mils. But most of the time 10 mils won't be enough because the spread won't be that nice. So that's the advantage of using ultrasound because we can see the spread. So maybe 20 mils is enough, 15 mils is enough if the spread is good. Okay, so this is another way of you ergonometrically standing in a straight line. Okay. If you notice, this is the position if the patient is left-handed, meaning that the right hand is holding the probe, the left hand is the one that adjusts the needle. So if those who are left-handed, their positioning is a bit different. So you have to find your own position. Okay, for a supraclavicular block, it's quite easy. Just place your probe parallel to the clavicle on top of the groove. Okay, and make sure that you rest your fingers or your wrist on top of the patient. Okay. And patient's head is turned away, and this patient is this model is in 45-degree position. You can either put a sitting or 45-degree. Okay. So how we are going to do it is that this is the first image that we want to see when we put our probe on top of the groove. Okay. The brachial plexus on top of the first rib. It is like a safety measure so that when we advance the needle, over-advance the needle, we are poking the ribs instead of the lungs. Okay. And then this is the artery. This is actually the middle scaling muscle. Okay. So for a supraclavicular block, initially we advance our needle at 6 o'clock of the brachial plexus. There's like a pocket here. We are aiming towards the pocket. So we just go inside there. We deposit, let's say we are planning to give 20 mils. We deposit 10 mils here, and then we see the spread. Sometimes the spread can, the LA can spread up until here. So it's actually quite good, meaning that we are inside the nerve sheath. But sometimes it only localizes here, so it doesn't cover up here, meaning that we don't cover the superior trunk, everything, upper trunk. So, but we want to cover those trunks as well. So we pull out and then we advance our needle here to give another half to cover up the whole brachial plexus. Because remember that we are here would be the trunk and or stroke division, which is the upper trunk, middle trunk, and lower trunk, inferior. So we have to make sure that it's covered properly. Okay, and then so we can see that here we can see the tip is here. So let's say if the tip is overshoot, can still have the first rib to protect. Okay. So the artery that we have to watch out for supraclavicular is there's this one artery here, dorsal scapular artery. Okay, as you can see here, there's no artery here, but a slight tilting of the probe might make the DSA artery appear. And then sometimes it looks like a muscle. Sometimes. So we have to put some Doppler or artery to make sure that it's not a vessels. And this dorsal scapular artery actually divide the trunks. If you can see, this is part of the upper trunk here, and this is part of the middle and the lower trunk here. So they actually divide the trunk. So this is not the optimal position that we want. So this is the optimal position that we want, so that it's not divided. The rest of the complication that we are worried of would be the pneumothorax things, everything. For phrenic nerve injury, for Horner syndrome, everything, there's a possibility of happening in supraclavicular block, but it's very, very, very rare. Still need bear in mind. Okay. So why I choose to talk about this small nerve block, the intercostobrachial nerve block, because for this is the only part that is not being covered by the supraclavicular block, because the intercostal nerve arises T2. It arises from T2. Our brachial plexus is from C5 to T1. And then let's say if we are planning to do some kind of a laceration wound operation that extend up until axilla, we need to top up with this nerve block in order to get some pain relief. Okay. So the concentration For this kind of block, the concentration is 0.2 or 0.5. It depends. It will affect the duration. The volume would be around, maximum is only 5 mils because the nerve is very small. It can be done percutaneously or ultrasound. Okay. And then the needle that we use is actually our blue needle. We don't need a block needle to do it. Okay. So where and how, this is basically how we do it subcutaneously. Okay, we infiltrate it here. The hand position it like this or fully abduct away. But let's say if you want to do it under ultrasound, since we are already, like for a fistula operation, we already use the ultrasound probe to do a supraclavicular. You can just use and try to image this intercostobrachial nerve here. This is actually the bicep muscle, axillary artery. This is the deep fascia. This is the teres major. So most of the time, under ultrasound, we cannot visualize the nerve. So what we do is that, this is the needle direction. We just direct from here, from lateral side, going to medial, deposit the LA above the deep fascia. Okay. And then with 3 mils, you can see the deep fascia. And then if, let's say, you cannot visualize the nerve initially, after giving at least 2 or 3 mils, you can see there's a nerve floating around. So that's the intercostobrachial nerve. Okay. Ultrasound is most of the time 2.7 or 3 cm.
Bella,
Yeah.
kan subcutaneous kan kita subcutaneous macam tu kan. Kalau using the ultrasound, just satu poke.
Yeah, just satu. But we have to actually we have to poke here deep fascia, and then we slowly withdraw while giving it, so that we are giving it on top of the fascia. Because we cannot visualize the nerve, we don't know where the nerve is. But let's say if we can,
Facial now. Giving to the facial and then withdraw as injected.
yes, we try. If we can see the nerve like this, you can actually see the nerve here. So we just inject it there. But you cannot see, because most of the time we cannot see it.
Yes, where actually is your insertion point when you're doing the nerve ultrasound?
Here, from here.
So you're coming from the top.
Coming from top. Because you'll be standing here, you'll be giving the supraclavicular here, and then you just put the probe here, and then come.
No, without ultrasound.
Without ultrasound? Without ultrasound also here. Lateral.
Where?
Here. Yeah. Here. Around here.
So just where the tricep is inserting, just on top of it.
Yeah, border of the tricep. Yeah. Teres. Yeah.
See, that's when you feel it, right?
So that's why most of the time we can just do it subcutaneously, but we can do it under ultrasound.
Dia lemak.
Okay. Okay. So, my next topic will be the vascular access. Basically, we tend to do it blindly, but why do we need ultrasound? Just because we have ultrasound machine. And then another thing is that to reduce the complication, and also to shorten the performance time. And then before we want to use the basic things, is still basic, we need to know the anatomy of the vein and of the artery, and also the vein. And also on the ultrasound sonoanatomically, what's the difference between the vein and artery? Okay, the pulsatile part is a bit controversial, because if let's say the artery is sitting next to the vein will be pulsating as well. So these the 3 other qualities would be things that we look out for if we are looking at vein versus artery, because both will be hypoechoic, will be black. Okay. So there's a few ways of doing this vascular access, like Dr. Zadak mentioned earlier. We can do it in plane or out of plane. Okay, in plane meaning that our beam will be parallel with our vessels. Okay, and then if we can see, this is the needle, assuming this arrow is the needle would be very near to the probe. And then we only move the needle. We don't really move the probe, meaning that we get an optimal view of the vessels that we want to poke, and then we move the needle to advance the needle. If you can see here, the initial placement of needle is slightly going to be out of the way of the ultrasound beam. So I just advance the needle a bit inside the beam, and then we can safely advance it. This is the in-plane view. Okay. But why most of us doesn't like this in-plane view? It's actually safer because it won't be overshoot, because we are not looking only at this dot. But the problem is our body structure. Okay. In order for us to put a probe parallel, if let's say, okay, if I choose our cubital fossa, how often can we put our probe truly parallel on top of the skin fold? Because we got the fold there, everything, and so it's going to change the image of the ultrasound image. So that's why we tend to put our probe transversely, which is out of plane. But out of plane, problem would be we have to simultaneously move the needle and the probe in order to get this optimal image. The needle inside the vein. So the initial part would be the needle would be very near to the probe, and then as we advance and up, the needle would be around 1 centimeter away or 2 centimeter away from the probe. So that we have to make sure that the problem with the short axis out of plane technique is that the beam is here. It's only here, and we are trying to put this small tip of needle at the beam. Compared to here, the beam is quite huge, and you can just play around with the tip. But this is the most of the time we use this plane because of our body structure. Okay, so few tips. The needle bevel has to facing towards or away from the ultrasound beam, meaning that if let's say the bevel is like sideways, it's a bit difficult for us to know where's the tip. So it's better to face forward or away. Away meaning that 180 degree away. And then we avoid putting too much pressure, because vein is compressible, especially those who are under volume. If we put too much pressure, then we are going to poke the artery all the time. Okay. And then remember that in plane technique, the probe is static, meaning that we don't move the probe. We get the optimal view, and then we put the probe static, and then we just redirect the needle anywhere that we want. For out of plane technique, we have to move both together simultaneously, so that we can get the good vascular access. Okay. Anything about the upper limb and the vascular before I move on to the scalp?
How long will you observe the patient if you want to discharge, let's say, a patient with verbal dislocation or shoulder dislocation, and they want to use glove? Anything to watch out before I discharge the patient?
Before we discharge the patient, we have to look at the neurological examination.
So you worry about what causes?
Yeah, we have to check for the numbness and the weakness. Preferably is no numbness or no weakness. But let's say, because there's an incident of neuropraxia, so we gave time like 2 weeks, and then ask them to come back again.
So
If you want to discharge straight away, because let's say you want to do it at daycare or something like that, or how is it? Emergency department. So let's say if you want to do, you have to have a follow-up system. If you want to discharge this kind of patient, you have to have a follow-up system. Because we don't know whether it's going to be a neuropraxia or because of the block that's working.
But you mean just about the neuropraxia because of the injury or because of
because of the block. The neuropressor can be because of the block. So if we want to discharge those patients, we have to have a polaris.
I was thinking 0.25 mL in 6 hours. Not good enough.
It's good enough, but it's a bit difficult to say.
I think it depends if the patient is going to admit to the ward, so
Yeah.
it's okay. But if you want to do some procedures, so maybe you need to adjust your concentration accordingly. Yeah, it depends.
If patient is admitted to ward, it's okay. We can just follow up in the ward. But if discharge home, that's how we have to think. Yes, that's how.
You have the tips for us in the vein access, like the entry points of the needles. Because in plane, we say it's very near to the probe. But you have to remember the probe is sitting like that, and we're seeing it like that, right? So if you have entry points to, then you nampak lah needle tu sama, like it should be like that, right? But sometimes you will not get it. Because you nampak dalam tu, actually the blue is just like that.
Yeah. So that's why we have to move the needle. We have to make sure
So
that
when I move the needle, what do I just nampak straight juga kan bawah.
you should be able to see the.
Bila you nampak vein tu gambar macam tu kan, I masuk macam ni. Kalau I masuk macam ni pun dia nampak juga. I tak masuk macam ni. I mean, you get me? I'm like that. So if kalau ni vein, I masuk macam ni straight, I nampak tiga line.
But there's no
Kalau
back
I
flow.
masuk sini pun tiga line. Dalam view. So do you have any tips untuk kita masuk macam tu?
Untuk masuk straight, exactly like that.
Kadang-kadang I masuk sebelah vein, I still nampak tiga line kan.
That one is in plan lah. So usually we can perform with out of plan.
Then you have to confirm again lah.
Yes. To get the target side.
I nak senang.
Best practice, you tend to isolate layers of butters prior to closing. Deal with water. What's your advice?
Hydrodissect. Okay, let's say if you can visualize the tip, you are pretty sure the tip. We don't normally do a hydrodissection. Okay, but let's say you are still new in block. You are not sure. You are not sure. You can use it. You can choose either saline or D5. Okay. We don't give hydrodissect like until 10 mils. No, we give 0.5 mils because with 0.5 mils you can visualize it in under ultrasound. 0.5. Because sometimes for us that was very new, we don't know whether it's a shaft or tip. So you don't know, you can give 0.5 is enough. 0.5 mils. Okay. So now we are going for a scalp block. This is under the request of our neuro NS. But for scalp block, it's actually can be done as part of anesthesia as well. So why we do it? Basically, if patient got a laceration wound, we just want to top up a bit more. Most of the time, surgeon will supplement the LA. But if you want to learn, then I think this is the time where we can learn. For a scalp block, there's a 7 main nerve that we want to block. So it looks complicated, but it's actually very easy. Success rate is very high. Yeah, very high meaning that almost 100% for first timer. Trust me. Okay, so let's say if we want to do a burr hole operation, we got for burr hole we got this frontal hole, temporal, and sometimes parietal. So for frontal part, we have to block the supraorbital nerve, supratrochlear nerve, and also the zygomaticotemporal nerve, which is here. For the temporal part, we just need to add up auricular temporal. And there's this one nerve that this picture means out is the greater auricular nerve behind the ear here. And also if let's say we want to cover the posterior part of the scalp, then we should cover the greater occipital and the lesser occipital nerve. The problem with the scalp block is that we are afraid of hematoma because supraorbital artery running just next to the supraorbital nerve. And also we have this superficial temporal artery running through here. And then we got this occipital artery as well running through the greater occipital nerve. So let's say patient is very high risk, got double antiplatelet, those sort of things. We might want to consider not doing the scalp block. If let's say we are not that confident. But let's say if patient is straightforward case, then we can just give a scalp block as a part of anesthesia part. So where to poke? Okay. We can do it under ultrasound guidance, but it's actually quite difficult, personally speaking. So it's easy to do by landmark technique. The first landmark that we have to look at is the supraorbital notch. Okay, most of us don't know where is the notch is. So easy way to do it is ask patient to look upwards, straight, and then from the base of the nose, in the middle, base of the nose, up until next to the eye, roughly 2.5 centimeter away would be your supraorbital notch. This is by calculation. If we cannot feel for the notch, this is by calculation. So how do we do it? We just poke it at the supraorbital notch, below the eyebrow, hit the bone, which is very superficial. We only use the insulin needle, the very short needle. We don't use the blue needle. The blue needle is considered quite long for the scalp block. We just poke it, hit the bone, we draw a bit, aspirate, no blood, we give around 2 to 3 cc. That one is going to block the supraorbital nerve. And then we just, using the same injection site, we just redirect medially, because if you remember the previous picture, the supratrochlear nerve run medially from the supraorbital nerve. So we just go medially, inject another 2 to 3 cc. Then you are going to have a big wheel here. To block the zygotemporal facial nerve, we palpate for the supraorbital margin. This one is easy to palpate. It's just at the edge, the margin, and then we can feel for the zygomatic arch. So we feel for the margin, we poke the nerve, we poke the bone, we remove a bit, and then we aspirate, no blood. We inject while advancing towards the zygomatic arch, so that we create a wheel here, along here, the arch here.
What's the indication for
This is for any kind of laceration wound or a burr surgery. Huh?
For TNS?
Can? TNS can. And then for auricular temporal nerve, we just look for the tragus. 1 centimeter away, feel for the superficial temporal artery. We just inject 2 to 3 cc. This one should cover the frontal part. Meaning that if patient got a laceration wound here, you don't have to do the posterior part. This is the posterior part. We don't have to palpate the occipital protuberance or mastoid process. It's enough by doing all the 3 injections.
Cover unilateral.
Unilateral. Then, if let's say we need to cover the posterior part, the 2 landmarks that we have to know is the mastoid process and the occipital protuberance. This one we can feel. It's easy. Yeah. Mastoid process will be down here. And then occipital protuberance. It's a bit difficult to feel the occipital protuberance, especially if you have a thick hair or something like that. But you can feel for the artery. There's the occipital artery. Near the midline there, you can feel for there's an artery there. So by calculation, the landmark would be, mastoid process would be 2 centimeter away from our tragus. Okay, 5 centimeter, and then the the point where the greater occipital nerve run through would be 5 centimeter away from our ear. This is by calculation, landmark by calculation, not by the landmark palpator. But don't worry, the success rate is very high. So what do we need? Only a sterile glove, and the LA that we use is together with adrenaline. Most of the time we only use the concentration is 0.25. This is for both anesthesia and also analgesia. Anesthesia, the example for anesthesia would be the awake craniotomy that we can use scalp lock together with a sedation to perform an awake craniotomy. And then the total injection site is 5, but we are aiming for a total of 7 nerves and around 2 to 3 cc at each nerve. So if we add up everything, would be 20 cc per site. Okay. That's all for the scalp lock. For awake craniotomy, we can do. Okay, thank you. That's all from me.